Today, the title of our webinar is In-Stent Restenosis Treatment, Insight Study, and also case studies, which is really very delightful and very educational night. We're going to be spending the coming 1 hour with experts in the field. And starting with thank you to the sponsor, Avenger, for putting in this together, for sponsoring this evening program. That's, I think, at the end, you're going to have a lot of knowledge about a new imaging-guided in-stent restenosis treatment. Starting introduction with my co-moderator, Dr. Jaafer Golzar. He's a friend, a colleague, and like a brother as well. He's an interventional cardiologist and director of endovascular intervention at Advocate Christ Medical Center in Oak Lawn in Illinois. He's also the chief medical officer of Avenger and also director of limb salvage at Advocate Trinity Hospital. He serves as a clinical assistant professor at the University of Illinois at Chicago. Our speakers today, starting with Dr. Jon George. He's an interventional cardiologist and endovascular medicine affiliate at Pennsylvania Hospital in Philadelphia, Pennsylvania. He's also the medical director and CEO of Revasc MD Professionals. He serves also previously as a cath lab director at Albert Einstein in Philadelphia. Dr. Ian Cawich, he's an interventional cardiologist and coronary and vascular interventionist with a lot of experience at Arkansas Hospital Center in Little Rock, Arkansas. He's recognized as limb salvage and expert and regularly perform minimally invasive procedure with the most cutting edge and revolutionary technology, which is, I think, very, for his area, is a pandemic for patients who have severe peripheral arterial disease. And last but not least is Dr. Edward Pavillard. He is a board-certified vascular surgeon with Tower Health Medical Group at Phoenixville and Pottstown Hospital, where he also practiced for the last 18 years, specialized in both minimally invasive endovascular procedure and open vascular reconstruction, and also has a strong advocate for intravascular imaging for safe and more effective outcome. With that, I would like to turn it to my co-moderator, Dr. Jaafer Golzar, for his slides, as well as introduction for the OCT as a technology for endovascular therapy.
Thank you, Dr. Alraies. I truly appreciate you hosting our webinar tonight and being part of this really important topic about treating in-stent restenosis. And on our podium, we have, on our virtual podium, we have some of the giants of the vascular world and really pioneers in OCT-guided atherectomy and crossing CTOs. These guys have really pioneered this technology. They're great friends. I've known them for several years and really on the forefront. So what I wanted to do is, before we get started, and I really want to thank everybody for joining us tonight and being part of this, is, that's education and really progressing our field is so important because technologies continue to evolve, and we've really evolved so much if you think about it over the past decade. And this is one of the newest and most important, from my standpoint, technologies, because it is one of the technologies that allows you to see real time what you're doing. We have no other technology that allows live imaging during treatment. So when we think about real-time imaging, what we think about is the fact that, some of the fundamentals that we think about from treating patients with peripheral vascular diseases: safety and efficacy. So we want a safe device. We want to, we don't want to have perforations. We don't want to have distal embolization. We want to be able to treat these patients safely, but also we want something that's efficacious. And so when you are able to look inside the vessel in real-time image what actually you're doing from an atherectomy standpoint, it's unparalleled. And with this technology, you increase efficacy because you're allowed to see exactly what you're doing. You remove plaque only and remove as much as you want. And then you're allowed to do this safely without damaging the intima or adventitia, which we know can cause complications, but also can lead to restenosis. Now, just to set the stage a little bit for those of you that are not familiar with this technology, when we're looking at these OCT images, and we're going to see a lot of this tonight, what you're looking at is you're going to have this black circle. That's the cutter itself. That's what you're looking at. And what your leading edge is going to be opposite of these three bars that you see, or three lines. And so here, what you see as the leading edge or the cutting edge is at 12 o'clock. So just like any other directional atherectomy device, you have the cutter, and as you perform atherectomy, you then pack the plaque into the nose cone. And here you see the nose cone. And there's several different sizes for this device, the Pantheris device. So here you're seeing the 7 French device. And opposite of the cutter, you have a balloon. Now, this balloon allows you to dynamically control the depth of the cut. So you can really get either as deep as you want or as superficial as you want. And so what this allows you to do is, again, precisely cut the plaque without damaging any normal vessel architecture. And as part of using this technology, one of the benefits is not only do you reduce radiation exposure, because you should not be using radiation at the time that you're doing OCT-guided directional atherectomy, but you also decrease contrast use. And so these are really helpful. Those patients that have creatinines of 3.540, really using this along with CO2, you can have significant benefit because you can see exactly what you're doing without using any dye at all. On the left-hand side, you see the CTO crossing device, and you're again able to cross without the use of a dye at all. And then you can actually see exactly where you're crossing. And on the right-hand side, you see the atherectomy device. And at around 10, 11 o'clock, you see plaque. But around 12 to 3 o'clock, 12 to 6 o'clock, you see normal vessel architecture. So the beauty of OCT, we kind of are familiar with IVUS and intravascular imaging, so important because really identifying what you're seeing inside of the vessel. But OCT, as you know, provides so much more resolution than intravascular ultrasound does. And so one of the mainstays or the fundamentals that we think about, so you can see some really cool things when you're doing this. So you can see lipid pools, you can see necrotic cords, you can see deep wall calcium. But early on, when you're learning this, it's a really simple concept. You look for the external elastic lamina. And as you can see there on the right-hand side, that's that line that you see. So sort of the way I teach it is look for the EEL. When you see that line, that's what you don't cut. If you don't see the EEL, go ahead and perform atherectomy. And so that's sort of a simplistic way of thinking about it. Now, as your experience improves and you get better at it, then you can start seeing these really cool things like the lipid pores and really start focusing on what you're actually removing. Now, when we think about this, we'll go to the next slide. So when we think about treating these patients with peripheral vascular disease, so when we think about safety, obviously not damaging intima, media, external elastic lamina, but now we get into the world of ISR. And ISR is a big issue that we deal with instead of restenosis, because these patients come back, they're higher risk. And we know that there's several different products out there that are indicated. We are one of the newest indications for ISR. So when you think about removing in-stent restenotic plaque, this is a very different plaque than what you see in native vessel architecture. It's very rubbery. It's very difficult to treat. So, some people just do balloon angioplasty, but you're not really treating the underlying process. These patients need to have debulking. We need to actually remove that plaque and then some type of adjuvant therapy. And so when we think about directional atherectomy, it's great because you have really efficient outcomes. You have maximal luminal gain. But one of the challenges is that you can have safety issues. So you can disrupt normal stent, you can grab that stent. So when you're actually able to see what you're doing, you have significant benefits. So you can remove as much plaque as you want to, but really not damage any of that stent structure. So we're going to start by turning it over to our esteemed colleagues, our esteemed panel, because we have data behind this. This is not just me talking. We have the inside data, which was a really important clinical study that evaluated Pantheris OCT-guided directional atherectomy in stents and for treatment of ISR. So I'm going to turn it over to Dr. George.
Thank you, Dr. Golzar. Good evening, everyone. It's a pleasure to be here, part of this esteemed group of interventionalists, and talk to you about the In-Stent trial. So as you know, and as you've heard from Dr. Golzar, this is a problem that we're all faced with: in-stent restenosis. And what do you do in this setting? You have neointimal hyperplasia encroaching into the lumen of these stents. What are your options at this point besides just balloon angioplasty? And so atherectomy as a whole within this subset has been extremely difficult. And the reality is that whatever atherectomy that you do, outside of laser atherectomy that has an indication for this, any other sort of atherectomy, would be it rotational, orbital, even directional without onboard imaging, is a risk to those stent struts and damaging those stent struts. So that's where Pantheris comes in. And this is the reason why Avinger specifically looked at where the advantages would be, the advantages would be to utilize directional atherectomy with onboard imaging with OCT. So this is what Pantheris brings to the table, and this is why within in-stent restenosis, this shines, because you're able to see where you're going. So as you look at these images, you've already seen from Dr. Golzar's presentation what OCT imaging looks like, how you can see the different layered structures and de novo vessels and lesions. But within stents, what you see on the left panel is the actual stent struts. On the right, you see the actual fluoro image of the catheter within a stented segment. And with the markers that you see with this onboard imaging catheter, you see that there's 3 markers at around 3 o'clock. And away from those markers is where the cutting is actually occurring. So you're facing those bright stent struts that you see. So you're confidently cutting that neointimal hyperplasia till you get to those actual stent struts. So you have clear visualization with OCT imaging without utilizing angio or fluoro. Here are some stock images from the trial where you have pre-images of in-stent diffuse restenosis with occlusion, and then utilizing in the middle panel the Pantheris device, directional atherectomy with OCT imaging, and a nose cone to collect the debris. And then finally on the right panel, the post-result following atherectomy and angioplasty with excellent flow through that segment. So let's get to the trial and the data behind this. So In-Stent stands for Evaluation of the Pantheris OCT Imaging Atherectomy System for Treatment of In-Stent Restenosis in Lower Extremity Arteries. So what was the trial design? It was a prospective global single-arm multi-center trial. There were 17 sites total, 15 in the US and 2 OUS in Europe. 97 patients per protocol, patients that were enrolled, and all of the images from these studies were core lab adjudicated with the adverse events that were assessed by a clinical events committee. So all done with a third-party evaluation of the images to make sure that these are adjudicated and not operator dependent. And I was fortunate, as with many of our panelists, to be part of this trial. Pivotal trial for this device in in-stent restenosis and getting that indication. The safety endpoints, the primary endpoint was freedom from major adverse events through 30 days. The secondary endpoint was incidence of new or worsening stent fracture post-atherectomy. So the reality is you're using direct onboard imaging, and so you can see those stent struts and be able to tell what you're looking at and not damage the stent struts. And then the effectiveness endpoints with primary being residual diameter stenosis less than 50% directly post-atherectomy, and then secondary residual stenosis of less than 30% post-atherectomy, and freedom from TLR at 6 months. So those were the safety and the effectiveness endpoints for this trial. So what's important is that there was 93% freedom from TLR at 6 months in 85 patients that were followed to that term. At 12 months, which were 76 patients followed to that endpoint, there were 89% freedom from TLR. So this is pretty impressive for an atherectomy device in diffuse in-stent restenosis, which is a challenging subset with minimal options. And so 89% of those reach that efficacy endpoint of less than 50% stenosis post-Pantheris. That's just with atherectomy. And then 82% reach the luminal gain post-Pantheris and adjunctive therapy. 100% freedom from amputation at 6 months. So no one had amputation at 6 months. As far as safety endpoints, freedom from major adverse events at 30 days at 97%, and the same maintained over 6 months. So extremely efficacious and safe in the trial. So these were the In-Stent investigators, and you'll see them across the map. And like I said, many of our panelists were involved in this trial as well. So they can all attest to the success of this trial. So here are the patient demographics. I mean, they're pretty routine. If you've been seeing these peripheral vascular disease trials, you'll see that they were primarily class 3 Rutherford patients. They were primarily Caucasian, 50-50 male and female. ABI average of about 0.7. If you look at the risk factors, they spread out for all the risk factors that we see for peripheral vascular disease. So, very typical subset of patients that we see for PAD. If you look at the characteristics of these lesions with in-stent restenosis, the reference vessel diameter was about 5.5, lesion length of about 13 centimeters, and then diameter stenosis of about 87%. If you look at the location of the lesion, primarily SFA pop, which most were SFA, and then about 6% popliteal. If you look at calcification, you'll see that they're mild to some mild, some moderate, but mostly no calcification, which makes sense for an in-stent restenosis trial, which is primarily neointimal hyperplasia. And so if you look at this effectiveness endpoint from pre-stenosis, you have an 82% luminal gain post-Pantheris and post-adjunctive therapy. So as demonstrated, very successful in reaching that technical success. 89% of the 97 ISR occlusions had a residual stenosis of less than 50%. And all the secondary endpoints were met as well, with 93% freedom from target lesion revascularization at 6 months, 89% at 12 months. And what's really interesting, look at the procedure time, 11 minutes of Pantheris. That's it. So it doesn't take long when you're directly treating what you're seeing with the eccentric or concentric restenosis. You're looking at what you're seeing inside the vessel and targeting the therapy to what's visible to you intravascularly. So let's look at the competitive data. Like I said, there's only one other atherectomy device that has the indication for this. I actually was also on that trial with the Excite trial when it was first introduced for laser. So I'm very familiar with this data. And it was very successful, and we didn't have very many options at that time. And so utilizing laser in stent is safe. But the problem is the freedom from TLR. It's very efficacious at the beginning, but it doesn't last. You see that significant drop-off in the freedom from TLR after that initial success, technical success. And so that's really the effectiveness comparison that we need to make here. If you compare directly Pantheris plus angioplasty to laser plus angioplasty, if you look at the freedom from TLR, again, these are not head-to-head trials, but this is comparison of both of the trials that were done for indications. So Excite trial for laser, Insight for Pantheris. You had 93% freedom from TLR in 6 months in a very similar in-stent restenosis population compared to 74% in the laser trial. And if you look at 12 months, 89% versus 42%. So significant drop-off over time with laser, unfortunately. So the conclusion is that there's very little decrease for Pantheris for freedom from TLR between 6 and 12 months. So it's maintained, that patency is maintained in their individual trials as opposed to laser, which had the 2x drop over from 6 to 12 months. And then if you look at the safety endpoints, you'll see that it's pretty safe. The major adverse events were extremely low. Like I said, these adverse events were adjudicated by a clinical events committee. And so if you look at Clinically driven TLR, there was one case out of 97. Obviously it was a Pantheris case in In-Sight, and so it has to be attributed to Pantheris. And then as you look at the device-related events, there were no clinically significant perforations. There were 3 clinically significant dissections. Now, this is in the entire procedure, so none of them were attributed to Pantheris. So this was attributed to the post-Pantheris treatment, whatever that was, with balloon angioplasty or whatever else was utilized following the Pantheris. So none of those were assigned to Pantheris by the CEC committee. And as far as clinically significant embolus, there were 2 cases that had embolus, but we advocate doing these procedures with distal embolic protection, as we do, as is recommended for most directional atherectomy cases. And so this is extremely safe. But nonetheless, it's only 2 cases in 97 procedures that were done. No pseudoaneurysms. And then other endpoints that you can look at, again, at 6 months and at 30 days and at 6 months, 97% freedom from major adverse events, 100% freedom from amputation, 98% freedom from TLR. And you'll see that the drop-off between 30 days and 6 months is not that significant. It's identical for major adverse events and amputation, a very little drop-off in TLR, mean ABI measurements about the same, in fact, maybe even a little bit improved, but not statistically significant. So you'll see that the patency is maintained over time and the effectiveness is maintained over time. If you look at the Rutherford class, the baseline, I told you 55% of them were Rutherford class 3. And at 30 days, majority of them, 43% was Rutherford 0. And again, maintained or even improved at 6 months with 53% at Rutherford 0. Again, emphasizing the maintenance of the effectiveness at 6 months and 12 months. This is more of the same, but if you look comparison here between Pantheris and laser, you'll see the freedom from major adverse events at 6 months is 97% versus 79% for laser. If you look at the ABI at 6 months, you'll see that there's a significant improvement at 6 months for Pantheris, which is the red bars, as opposed to laser, which is the gray bars. So again, improvement in symptoms for patients. So if you look at the other comparisons in the trials, the mean length, laser had slightly longer length of lesion, but otherwise very comparable, 82% versus 85% stenosis. And then if you look at freedom from TLR, that's where things differentiate. So the effectiveness significantly better with Pantheris, and the mean ABI, as I pointed out, at 6 months, that significantly improved with Pantheris. So if you compare Pantheris versus laser versus just plain old angioplasty, at 12 months, laser is approaching what plain old angioplasty would be at 30%, and lasers at 42%, while Pantheris is maintained at 89% of freedom from TLR. So what are the conclusions here? Pantheris offers the best combination of safety and efficacy for in-stent restenosis, best-in-class performance for treating ISR lesions with direct visualization of the plaque and targeted treatment, sustained outcomes over 12 months as demonstrated across all metrics with ABI, freedom from TLR, and then also positive data from In-Sight that FDA actually ended this early and approved and granted the indication with only 70% of the subjects specified in the protocol. So with that, I will pass on to the rest of my colleagues for the additional case studies where you can see its effectiveness. Thank you again for your attention.
Thanks, Jon. Excellent presentation on the data. We're going to talk a little bit about a real world case that I did several months ago using Pantheris. It was a 250 millimeter left superficial femoral artery in-stent restenosis that was totally occluded. We treated basically for proximal to distal edge of the stent and had good outcome with it. So patient was a 74-year-old male. history of peripheral vascular disease and hypertension, complaining of Rutherford 3, and also had multiple interventions both on this leg and the other leg. The lesion was estimated to be about 250 millimeters, had multiple stents in that area. As you can see, it occludes right at the bifurcation with the profunda, which is quite common. And since the stent was entirely placed throughout the entire SFA right to about Hunter's Canal, and you see reconstitutes at Hunter's Canal, you see that there's also some disease at Hunter's Canal all the way into the popliteal. Popliteal itself looked very favorable, as far as not significant disease. We accessed the right common femoral artery under ultrasound guidance and crossed over and put a 7x45 French sheet. We didn't use the glide advantage and an 035 support catheter to cross the entire length of the lesion. It was somewhat fibrotic and a little difficult to push through. So that to me signified that it wasn't a lot of thrombus, so it wasn't freshly occluded. That makes a huge difference in that, you don't want to treat fresh thrombus with something like with OCT-guided directional atherectomy. So there's a lot of fibrotic tissue in there, a lot of neointimal hyperplasia. And so it's a good one to go ahead and perform directional atherectomy. The other thing to me that I look for is how much of a landing zone I have. And so I can see here that, I basically comes back at 25, and I have at least, 20 millimeters of, of landing zone. 250 millimeters of landing zone. So I have a good landing zone for me to filter down. And in addition to using the filter, it helps me decide whether I want to use the Panteras A400, which is the short nose cone, versus using the Panteras A400X, which is the long nose cone. So here, since I have such a good long landing zone, I have more than 9 centimeters. I know that I can treat with the A400X. I don't have to be taking out the Panteras as often if I use the short nose cone. So since I'm going to be treating such a long lesion, I know I can use the A400X. If I had disease down in the pop and I wanted to treat down here, I may opt for the A400, the shorter nose cone, but that would mean more insertions and cleaning it out more often. So this one, I did choose the A400X because of the good landing zone, and I know I won't be interfering with the filter whenever I take in the nose cone. So initially, what I like to see when I put in the filter is when I put in the device, I see that, this is well away from the stent struts. I can identify that with this concavity of the stent struts that I'm in the lumen of the vessel. My first few passes through something like a CTO will always be without the balloon. So I'll open up the cutter and I'll advance. And then there's some markings on the device, on the shaft of the device, that can tell you how far you go. You want to cut about the length of the nose cone, and then you want to pack. And so I can cut and pack all the way down to get to the distal end till I leave the stent. And so I don't need to use much fluoroscopy. And again, in the first passes, I just do it without the balloon, because what you can tell is by the 3 markers that these 2 lateral markers are inside the plaque. And so that the cutter is well engaged into the plaque, and so you're actually going to be cutting plaque. You can see it again on this side, that the markers are again inside the plaque, and so that you're cutting when you're advancing. So those are the things that to me tell me that I'm cutting very well, staying away from the stent struts. And like I said, the first couple of passes down the CTO tell me that I'm creating a channel so I can get more aggressive when I come back. Now, these are things that I look for whenever that I'm very careful at. If you looked at the fluoroscopy, you saw that there were a lot of overlying stents. We've seen throughout these OCT images, these OCT treatments of in-stent restenosis, that a lot of times when we deploy overlapping stents, if we don't debulk and we just treat the just balloon angioplasty and deliver new stents, a lot of time that second layer won't go fully opposed to the first layer. And because you have a lot of neointimal hyperplasia behind the stent strut you can't get past. And so I tend to be very careful when I get close to these overlap areas, simply because I don't want to catch one of the stent struts. you don't want the cutter to get stuck on one of the stent struts. What we've seen is that a lot of times those overlap areas, the second stent will sometimes be even restenosed by 50%, and you could see that that's a good lesson for you to also think that if you're going to place an overlapping stent, that you make sure that you don't have any tissue there in that area, because otherwise you won't deploy that second stent overlapped area very well. And so you can see here that we could see that the stent struts are not completely opposed. So these are the areas I'm careful with when I have the balloon inflated to not to interact with them. If you do interact with them, don't close the cutter, just pull back a little bit, and then you could close the cutter. And then here again, you could see that the stent struts are well out in the distance, and you can see that the characteristic of this tissue is just, is all neointimal hyperplasia. And so, you can tell that you're actually cutting away a lot of this scar tissue. Again, here you can see that advancing, now we have our balloon up. And that's one of the things you can also tell when you're cutting, is you can see how much you balloon, how much balloon you have. You can control the depth of your cutter by inflating and deflating the balloon. And so you could see that you're getting close to the stent strut. At this point in time, what you want to be careful with is you want to make sure that you leave just a little bit of layer between the cutter and the stent strut. You don't want to get right opposed to the stent strut, because you have to remember that the cutter is just 1.2 millimeters away from the cutting device. So your cutter may interact with the stent strut before you see it. So I usually like to leave just a little bit of layer between there, but I can control how the depth is because of the balloon that gives me that controllability. And so again, in this picture, you see the stent struts, and you can see that, how well you can get close to the stent struts. And again, here you can see that the balloon is inflated because I'm now trying to use the balloon to get well engaged into the plaque. And so again, what you want to do is you want to basically try to remove as much of the plaque, in quadrants. So what I usually start is I'll find an open where the plaque starts, and not so much in a CTO, because CTO you have circumferential neointimal hyperplasia throughout. But if you have an area where it's not as concentric, you can start cutting from the edges, and you could come back and see the troughs and work your way around it. And so here you could see that you have a lot of neointimal hyperplasia. And again, this is one of the areas that you can try to maximize the full inflation of the balloon to get a good contact with the neointimal hyperplasia. One of the things that if you are pushing and you have some resistance, if you release on the balloon just a little bit, it'll allow for you to still cut through without having that, without the balloon, because the balloon is so inflated that it doesn't allow you to push. And then after that segment, you're able to again reinflate the balloon. And when you may come back for your second or third pass, you can then be a little more forceful with the balloon because you've already created a channel. And so what I tend to do is I mentioned earlier, I tend to measure how much I'm going to cut, and then just cut that amount, pack, and then take it and then bring it back again, and just do multiple passes, and I could see usually by that time you'll start seeing there be a little more blood flow and a little bit of change in the image, because you're having better blood flow and because you're debulking. So here you see that we're actually advancing the catheter, and you see we get close to the stent strut. You see the balloon size changes as I get close to the stent strut, because again, I don't want to get close to the stent strut. The other thing here you saw is that where the change to where I packed, I always pack before I deflate the balloon. So what we've seen is that sometimes if you deflate the balloon before you pack, that you'll have if you deflate the balloon before you pack, that you can leave some of these little strands that you can see that we used to call them hanging chads in the beginning. But so the goal is to be able to cut as close to the stent strut as you can before you deflate the balloon. And then again, on this other image, you'll see I'm inflating the balloon. You see the balloon going up, and it pushes me towards the stent strut. Here I can control with the balloon how close I get to the stent strut. Again, this is one of the things that's very beneficial for using Panteris, as opposed to another directional atherectomy device, because you can tell here how close you are to the stent struts. You're able to tell exactly how, that you can avoid the stent struts, any damage to the stent struts, while trying to maximize your how much plaque you're removing, so, and as Jaafer mentioned earlier, this is one of the things where you actually have live imaging while you're doing the procedure. So it's quite different than when we're using some of the other atherectomy devices where we're just looking under fluoro, and you can see under fluoro maybe that there's some changes, but you're not actually using the live intravascular imaging as you would with Panteris. Here you can actually see, well, now when we pull back, you can see that there's actually troughs, and you can see that there's that you've removed plaque. So you're getting real-time data. Here again, you can see that we'll get close back up to the stent, and you'll see here that I had trouble advancing the catheter, so I deflate the balloon a little bit, and here I'm pushing, and then you'll see that it starts getting closer to strut. So when I have trouble pushing, I just deflate and inflate the balloon a little bit. That usually will get me through, gets me right up to the stent strut again, to where once I get close to the stent strut, then I can go ahead and pack. The other thing that sometimes I do is that while I'm cutting, you'll see that I will, if I get close to the stent strut, I start torquing the device a little bit so I can get cut more along the lines of the plaque. And you see there, I'm torquing along the stent edge while I'm still pushing. And so that just allows me to continue cutting without having to, if I've not cut very far, without engaging with the stent strut. Again, though, if I do get close to the stent struts, I'll just pack and part because I don't want to get close to the stent struts and get into trouble. So you see that our final results now after, post Panteris, we debulked these. We did about 4 insertions and cleaning it out. And now you see that, just post Panteris that we have good luminal gain. We've reduced it to much more than less than 50%. And so now here, is a good place because it is in a stent that, you can use adjunctive therapy, preferably drug, coated balloon angioplasty if you have that available, or, balloon angioplasty. But you can see that oftentimes, we'll get, I always take a picture post Panteris because it's amazing how much of a good luminal gain you get just with Panteris, and there's few cases at times where you feel good enough to just leave it alone without having to do some adjunctive therapy. So to me, the case highlighted some of the troubles that challenges you may have with using stents in treating in-stent restenosis, relying just on fluoroscopy alone. You can't tell how close you get to the stent strut. We've all seen those cases, or maybe had those cases where you interacted with the stent strut with maybe a different atherectomy device, and then it gets stuck and you have to break the stent off and call your surgeon and all these other different things. So it's good to be able to identify where the stent strut is and not have to rely and be able to stay away from it. The OCT guidance and the directional atherectomy allow you to, again, get close to the stent edges without disrupting the stent edges and any of the associated complications. And then the OCT guidance and directional atherectomy, again, you can get very good luminal gain because you can get right up close to the stent. If you take it, when you come back, you can see where your cuts are, and so you can keep debulking as much as possible. And so you get adequate luminal gain. And so Panteris provides, a safe and effective treatment for in-stent restenosis lesions. And as Dr. George mentioned, there's lots of luminal that you gain just with the post-Panteris. Thank you so much.
Thank you so much, Dr. Cawich. Just while Dr. Pavillard get his slide together, we have a couple of questions from the audience. What characteristics of the ISR occlusion factor in your mind that will determine the treatment strategy for ISR? Maybe quickly, starting with Dr. Golzar.
Any patient that has ISR, unless you're treating a patient that has a Viabon stent in place, those you don't want to do atherectomy at all. But really any patient with ISR, right, because it's the same physiology, pathophysiology, which is that the new intimal hyperplasia, there's some thrombus in it. Now, if, as Dr. Cawich was mentioning, if we think that this is mostly thrombus, that's a different story. So let's say you have a patient that's a month out from a stent or revascularization, they come in with acute limb ischemia, that's a very different story. We want to put thrombolytics in. But anybody else is going to be new intimal hyperplasia, as Dr. Cawich had kind of very nicely demonstrated in that case, is about safety and efficacy, right? Efficacy because he was able to maximally debulk, and safety because he did not disrupt the normal stent architecture.
Perfect. Dr. Cawich, this question to you again. Why did you choose to adopt OCT-guided technology? You're an expert, have been doing this for a while with different kind of tools. What make you adopt OCT-guided technology at this time?
So, I actually started off with directional atherectomy, and I was very happy with the result, with what I was getting as far as the debulking, but my results were not durable. I was seeing a lot of these patients come back, I started off with using OCT crossing catheters in the very beginning, and what I noticed was that that plaque in the native SFA was not concentric. And so this concept of cutting, 4 quadrants meant that because plaque isn't concentric, it's very eccentric, that cutting into 4 quadrants didn't make sense because you damage plaque. And so I really adopted OCT guidance because it allowed me to be able to just treat, the plaque and leave the normal tissue alone, right. leave the nidus for the in-stent restenosis alone. And it's kind of the same thing that pushed me towards in-stent restenosis, is that, I had a couple of cases where I had some problems with you interacting in the stent, especially in those overlap areas. And so again, looking at the OCT guidance allowed me to stay away from that stent strut, stay away from those areas. And actually, Avenger or Panteris is the only really time I like to do a post-Panteris picture, because you see the luminal gain. A lot of the other atherectomy devices out there, you don't get to see that luminal gain. So if you use the device and you take a picture, you don't see as much as you can.
That's great. Thank you so much. Dr. Pavillard, we can proceed with the slides.
First off, thanks for inviting me to the forum tonight. I appreciate the opportunity to present a case that we had recently. The case here is a 250 centimeter long SFA pop stent occlusion. This is a patient who I had referred to me after another colleague had left town. I wasn't 100% familiar with his previous interventions, so I took a little bit different approach with this one. I don't necessarily always cross every stent occlusion with OCT image guidance, but because I hadn't done his original interventions, that's why we chose to use the Ocelot catheter in conjunction with this. If it's something I'm a little bit more familiar with, then sometimes I would try it with more conventional catheters and wires, and not necessarily pull out the Ocelot. But again, I wanted to get the interluminal imaging for the crossing portion to decide if I was going to use it. So here we have it. These are the initial images. This is in the proximal superficial femoral artery. There's unstented segment. The stents start in the proximal thigh and extend all the way down through the popliteal artery. This is a 79-year-old male, Rutherford class 4. ABI was 0.54. This guy actually moved up his procedure just because of the bad breast pain he had and was developing ulceration. The stents were placed over the past 2 years, and the most recent one was a little bit over a year ago. He had progressive symptoms rapidly over the past 3 months, suggesting that it's been going on for a little bit while. So I wasn't as concerned for fresh thrombus, which I would agree with the other panelists here. This is not the place that you want to put the device if you're concerned about any kind of fresh thrombus with it. It's not that it can't be used, but on instances where I've had suspicion for a combination of it, I'll use a combination of catheter-directed thrombolytic first to clear up any potential fresh thrombus, and then see what might be left over to use directional atherectomy for. All right, so here you can see these are the images of the crossing itself. We used the Ocelot catheter. It was a pretty quick and easy crossing, not a lot of resistance with that. He's got 2-vessel runoff after the crossing. And again, these stents extend all the way down to the joint space here. I would agree with the other comments earlier. This is one that we have potential to really debulk these vessels, and the beauty of the A400X is being able to collect a lot more material with fewer insertions. Unfortunately, when you get down to this level, I think that because there was some disease a little bit beyond the stent too, and I wanted to cut in the native popliteal artery, I chose to use the A400 to gain the extra length with the the cutter being closer to the nose cone. But I would agree. I mean, it does mean more insertions, and it's going to be a little bit more time consuming with the A400 over the A400X. But both are very good. But the A400X would be a preference if the stents end above the level of the patella. So here we have images. These are similar to ones we've seen before, but here again we have a clear image going through the crossing. And here we have a similar picture to what we had before, where there's overlapping stents. I like to see this with either the Ocelot or the Pantheris, which we have here. I've seen a number of cases where, if there wasn't good pre-treatment prior to placing a secondary stent, then you get a big gap in there. And I think those are going to be a nidus for not as good of a long-term outcome. But with the images you see here, we have a lot of distance between the cutting edge and the stents. Plenty of room to work here. I use a similar approach. I tend to pack a little bit more frequently. Here again, here's a live image. You can see the balloon is pretty well inflated. The other thing I try not to do is rotate and advance at the same time. Again, I want to try to keep the plaque headed directly towards the nose cone, so it gets collected in there without risking it embolizing. And I personally don't. I try not to deflate the balloon at all. I know some people say pack and then deflate. For the most part, I don't really deflate. In this last image here, I think on the right, again, it's the overlapping stents, and you can see them quite well. And in this particular case, towards the end here, you can see we're going into the native vessel where there aren't any stents. And I think that this is a real benefit for Pantheris, because everyone's seen the Tootsie Roll effect that you get from stents, where the edge of the stent you can get pretty clear, but then the disease beyond that, if you don't address that, then you're going to have limitation in the outflow. So big benefit for the image guided, but again, I think we get a lot of good images right after the atherectomy segment of it, where we can see a lot of luminal gain, much more so than you see anywhere else. I would agree that I personally don't use laser that much. I don't use it at all anymore unless I see an issue with the stent that I think we might get tangled up with it. But the debulking here is a lot more rewarding and satisfying, and it makes perfect sense, the long-term results from it all. And down the end you can see we had preserved runoff, no embolization. So I'm going to save some time for Jaafer. I know he's got some things to show you, but again, I would agree with what the other panelists have said here. This is for me, this is the best way to debulk these lesions, which I think is key for the long-term success of the interventions. We can clearly see the areas of neointimal hyperplasia that need to be removed in order to get successful long-term patencies with it. We can avoid the stents, avoid injuring everything, and address anything above and below the previously treated segments to get better long-term outcomes.
Thanks, Pav. Appreciate that. And I just wanted to piggyback on your presentation using the Ocelot and talk a little bit about the Tiger Eye, just a couple of videos. And really the reason I wanted to show this is because really it's fascinating to see what you actually see within these stents. So as you know, the Tiger Eye is the newest CTO crossing device, and it has a high fidelity laser, and we really get incredible images. And, you know, once we started doing Tiger Eye within the stents themselves, we've never seen images like this. So first of all, you see the segments of the stent that actually have nothing. They have no neointimal hyperplasia. They have a little bit of thrombus, but you'll see wide empty spaces within the stent itself. And this is, remember, this is just crossing itself. So you see, you know, there you see plaque, now you see open segments. And so when we're using other directional atherectomy device, now here you see thrombus. Is sort of this web-like structure. So, you know, when you're using non-imaging devices, you really don't know where should you be cutting, where should you not. So there's some more thrombus there. And so this is, again, fascinating because it also helps fine-tune your treatment algorithm. So if you see, hey, there's a lot of thrombus here, maybe you'll go with TPA first. So, you know, I really like using OCT imaging for the initial crossing. Just not only will you see these empty spaces, these areas of hibernating vessel, you may see thrombus, that which may not only change your algorithm for treatment, but you may say, hey, you know what, I'm still going to use directional atherectomy, but I'm not going to treat this little segment because there's a lot of thrombus there. I'm just going to treat the areas that I see of neointimal hyperplasia. So I thought that would be a cool video to show you guys, but I'll turn it over to Chadi. I know you have some questions.
That's great. I would like to thank the panel and everybody for your time, as well as for preparing the slides and for expertise and sharing the great cases using the technology, using OCT for guided Panthera's directional atherectomy. Many thanks to Avenger for sponsoring the session, and the thanks goes to our audience.